Hello, my name is Christy Evers. I am going to talk to you today about maternal obesity and preeclampsia. The purpose of this presentation is to show the causal relationship between obesity and preeclampsia in pregnant women. According to current data, more than 1/3, or roughly 36% of the adult population are in the obese category, and approximately 6.3% are considered morbidly obese. This data is using body mass index, or BMI, figures for classification. The prevalence of obesity is similar for both men and women in the United States. Medical costs for obesity and obese-related disorders is a staggering $147 billion US, and for obese people, the healthcare costs are $1,429 higher than those of normal weight. Many things are related to the cost of obese people, including missed days from work, more use of sick days, more use of healthcare dollars in doctor's office visits, emergency room visits, lab tests, and prescriptions for medications. Obesity has been addressed as a Healthy People 2020 goal and is a major problem in the United States. It is listed under the nutrition and weight status. Preeclampsia is classified as a hypertensive disorder of pregnancy. It occurs in between 3 and 10% of pregnancies worldwide, and 10 to 15% of maternal deaths are from preeclampsia. It is associated with increased risk of renal failure, stroke, cardiac arrest, and ARDS. The healthcare costs are about $7 billion annually. The progression of preeclampsia can lead to eclampsia, early delivery, increased lifetime cardiovascular risk, metabolic disease, and death. The American College of Obstetricians and Gynecologists, or ACOG, published a 99-page report on preeclampsia in November 2013. The pathophysiology behind preeclampsia is not fully understood. The risk factors have been identified, but without full understanding of the disease, it is difficult to treat. Fully understanding the reason behind the risk factors could help protect pregnant women. Preeclampsia is a pregnancy-specific disorder that has multi-system involvement, and it occurs after 20 weeks gestation. The diagnostic criteria are that the systolic blood pressure needs to be greater than or equal to 140 millimeters of mercury, and/or diastolic blood pressure greater than or equal to 90 millimeters of mercury on 2 separate occasions taken 4 hours apart. Proteinuria meeting or exceeding 300 milligrams in 24 hours, or a protein creatinine ratio of greater than or equal to 3.0 milligrams per deciliter in a single voided urine, or a dipstick reading of 1+ or greater. However, dipstick readings are discouraged unless only method available due to the unreliability. In the absence of proteinuria, new onset hypertension plus any of the following features also classifies as preeclampsia. These features are thrombocytopenia, a platelet count of less than 100,000 per microliter; renal insufficiency, which is a serum creatinine concentration of greater than 1.1 milligram per deciliter, or a doubling of the serum creatinine concentration in the absence of other renal disease; impaired liver functions, that is when there's elevated blood concentrations of the liver enzymes, including ALT and AST, to twice normal concentrations; pulmonary edema; and cerebral or visual symptoms such as headache or visual disturbances. There is also preeclampsia with severe features, and that is any of the following: any blood pressure systolic greater than or equal to 160 millimeters of mercury, and/or a diastolic greater than or equal to 110 millimeters of mercury on 2 separate occasions at least 4 hours apart while the patient is on bed rest, unless antihypertensive therapy is started before this time; thrombocytopenia, impaired liver functions, progressive renal insufficiency, oliguria, where the urine output is less than 500 milliliters in 24 hours, pulmonary edema or cyanosis, and a new onset of cerebral or visual disturbances. It is important to note that ACOG Executive Summary recommends using the terminology preeclampsia without severe features or preeclampsia with severe features. The three studies that were compared are seen on this slide. All three studies used the exposure of BMI to measure obesity, and the outcome was measured using ACOG criteria as seen on the previous slide, and elevated blood pressure with proteinuria. The strengths of all studies is that they all used BMI. All studies were also cohort studies, which on the spectrums of studies is a very reliable method. Study 1 also had several strengths. The cohort was predominantly obese, high risk, urban population, making it generalizable, so this study had a significant impact. Also, this study had a large number of morbidly obese women. Study 2 used a large cohort from 10 hospitals over a 4-year time span. Study 2 also used pre-pregnancy BMI as a more reliable method. This was also a hospital-based cohort and had accurate, reliable data to pull from, as well as a very large cohort. Study 2 also used a complete questionnaire for data that made it possible to account for a large number of confounders. Study 3 only included participants that sought prenatal care prior to 15 weeks gestation and used BMI data gathered at the first antenatal visit. Study 3 also used women that were recruited from different sites, and all were major urban academic centers, which makes the data generalizable. Some limitations to note is that Study 1 only measured height and weight for BMI at the time of delivery, and this is definitely a weakness as this may not be as reliable. Study 2 used recall data to gain data about BMI, which may lead to underreporting weight. As much as the studies tried to account for confounders, there's always a chance that not all confounders were accounted for. When we look at these studies, we see how the study population ranges from 2,637 participants all the way up to 10,196 participants. The exposure measured with each one was the BMI, and the outcome was preeclampsia or preeclampsia with severe features. Study 1 had 10,196 participants, and it measured preeclampsia with severe features. The exposure and onset was at greater than or equal to 34 weeks gestation, and you can see the BMI is broken out into 3 categories: overweight, obese, and morbidly obese. The adjusted odds ratio was measured. For overweight, it was 1.4. For obese and morbidly obese, the adjusted odds ratio was 2.0. The second study had a larger cohort of 49,964 cases, and the measurement was for preeclampsia. There was only 2 exposures, the overweight and obese categories, and you can see the adjusted odds ratio was 1.55 and 3.10 respectively. Although the third study had fewer cases, they still measured preeclampsia, and the exposure was broken out into 4 categories: overweight, class 1 obesity, class 2 obesity, and class 3 obesity. These larger breakout of numbers led to greater study results. You can see how the adjusted odds ratio increases as the obesity increases. Next, when we look at Henneken's criteria, we can see that the chance was, with Study 1, as the BMI was less with 25 to 29.9, it was not statistically significant. However, as the BMI increased from 30 to 39.9 and greater than 40, both of those BMIs were statistically significant. In Study 2, all overweight BMIs and obese BMIs were found to be statistically significant, as the one was not included in the confidence interval. In study 3, as you can see, the numbers of the BMIs as they went up became more and more statistically significant. The biases found in studies 1 and 3 were selection bias. In study 2, it also had selection bias being a cohort study, but it also had information bias. As you recall, we were using the recall data for patients from their pre-pregnancy height and weight. All 3 studies used a multivariate logistical regression to control for confounders. You can see in study 1 that with all of the risk factors for preeclampsia, many were controlled for, but there were some that were not. In the first study, the previous pregnancy complicated with preeclampsia was not controlled, as neither was in vitro fertilization. Family history of preeclampsia, systemic lupus erythematosus was also not controlled, and that was actually not controlled in any of the studies. The second study also did not have a previous pregnancy controlled or complicated with preeclampsia as a control for confounders, and they also did not count a woman who was giving birth for the first time, family history of preeclampsia, history of thrombophilia. For the third study, the only things that were not controlled for was history of thrombophilia and systemic lupus erythematosus. Remembering when you look at these studies that pregnancy is a very time-limited process. It only lasts approximately 40 weeks from onset to completion, so lack of follow-up was not seen in these studies as they were very short. Continuing, the strength of association, as you can see, study 1 was moderate, study 2 was moderate to strong, and study 3 was strong with the increasing BMI. It got stronger as the BMI increased. All 3 had a biologic plausibility, and they were very consistent. They all 3 came out with the same information. They all showed temporality, and they were all dose response. In conclusion, based on odds ratios, all 3 studies show an increased risk of developing preeclampsia with BMI in the overweight or higher category. Additional research is still needed to determine the pathophysiology of preeclampsia, and further research is needed to determine the importance of confounders with obesity. Thank you for listening to my studies. I appreciate your time. Here's the references used. Good night.